Radio MD. RadioMD.com. The world's preeminent talk radio portal. All about your health. And now here's Melanie Cole, MS, host of Staying Well.
Have you been a size A all your life and looked at the women walking by with their curvy figures and wondered, would I be happier if I looked like that? Or maybe you've had cancer and you've had a mastectomy and you need reconstruction now. What's involved in breast augmentation? What's involved in reconstructing the breast? My guest is Dr. Peter Geldner, and he's a Chicago premier plastic surgeon and founder of the Geldner Center in Chicago. So welcome to the show, Dr. Geldner. Tell us a little bit about breast augmentation.
Thanks, Melanie. Breast augmentation is probably one of the most satisfying aspects of what I do, and I do a full spectrum of plastic and reconstructive procedures. But I think that with breasts, it means so much in Western society and to the women in Western society. Let's break this down into two different categories, though. One of them is the kind of rejuvenate or reestablishment of something. In the case of a woman who's had children and has lost volume at the breast, and that's and put those into the same group as the women who always wanted to have something more than what they had. But it's a distinct category when we talk about breast reconstruction and those who have lost their breast to cancer or such situations where you'd have to rebuild something completely different. In the case of the aesthetic reconstructions, what we're really talking about is it's an option for women to get exactly what they want. I tell my patients that it's one of the coolest aspects of surgery that I do, because this is not determined based on what I want. Every woman knows what she wants to look like. You can walk into Victoria's Secret and you can walk out looking like Pam Anderson, or you can walk out looking like a boy. It's entirely up to you. So you know what fits your head, you know what fits your look, you know what fits your style. So through appropriate and selected types of procedures, we can actually give you exactly what you want, which is probably one of the nicest things about breast augmentation.
So now tell us, is there a best age or an age when you won't do it?
Well, no, actually. I think that certainly we want to be dealing with somebody who's mature enough to make a decision for themselves. I wouldn't consider doing this on a teenager unless there were extenuating circumstances. In terms of the oldest patient I've ever had was about 85.
Wow.
But I got to tell you, when she was done, she had the nicest looking body.
That's beautiful.
She was very logical.
And okay, now somebody that way can think pretty clearly. Do you wait till after you've had children? I mean, is this something that if you're in your childbearing years, not to do? Well,
I think that there are two different things you have to think about. One of them is that some people, no matter how hard they try, they won't have children. So if you're setting it on some kind of a hypothetical down the line, you're denying yourself something that you want, and that's a personal decision. I think that the question of can this do any harm to you, does a breast augmentation mess things up in terms of breastfeeding or having to do with children? The answer is no.
So you can breastfeed.
Yeah, we have to align the data, and there are some studies that suggest that some patients can have problems with breastfeeding, but as long as it's done correctly and you don't damage too much of the tissue, I've had a lot of patients who have had breast augmentations and have breastfed successfully.
And what about replacing the implants after a certain length of time? Do you have to, if you get these implants, and I understand that there are different kinds now,
yes,
so
absolutely.
Do you replace them, or are they good for life?
Basically, they're good for life unless there's a reason to replace them, and those reasons would be breakage or the patient's desire to replace it, or other complications having to do with the presence of an implant.
Now, some women, Dr. Geldner, look fantastic afterwards, and some women's don't look as natural. So why is that? Is that what they picked, or they went, too big for their body type, or why do some look so natural and some don't?
I think the most important thing is that you have to be realistic with a patient in terms of what their aesthetic expectations are. There are no hard and fast rules about how big you can go or how small you should go. I think it's really any patient who's contemplating breast augmentation needs to sit down with their plastic surgeon and have a real heart-to-heart discussion about this in terms of what their goals are and what's reasonable. If the doctor is unwilling to have that discussion with the patients, go find another doctor. Because the issue is that we can always strive to get as close as possible to that patient's desire. But to answer the question directly, sometimes it's a question of the patient wanting something that just doesn't make sense for her. In some cases, it's doctors who are willing to do whatever the patient says without putting any thought into it. So it's a complex relationship between the doctor and the patient, and dare I say, the science.
What about the difference between saline and silicone implants? How do you choose?
Well, back in 1992, the government told us that we couldn't use gel implants for primary augmentations. That was the gist of the moratorium which was imposed at the time by the Food and Drug Administration. So it wasn't that they felt that there were any evil things about it or that it caused diseases, but there were some very detailed things that went on with the FDA, and they didn't feel that the implant companies gave us answers. So that's when everybody started going with the saline implants. Saline implants are fine, and there are certain patients for whom it's a really good idea. But generally speaking, I reserve saline implants for patients who want saline implants. My default implant in most cases is a standard type of a gel implant. They tend to feel more like real breasts. They tend to look a little bit better than the saline implants. The saline implants have some inherent problems with them just by virtue of the fact of how they're made. But you know what? We also have a new implant now, which are euphemistically called gummy bear implants. These are the cohesive gel implants that come in different types of shapes, in different sizes, etc. And these are unique and have a whole new set of characteristics. These implants have been available in Europe and in Canada and Central America for the last 20 years. They're now finally getting their license, shall we say, or their approval by the Food and Drug Administration for use in the U.S.
Now, what about the costs involved, Dr. Geldner? Because this is certainly a limiting factor in this. It's not generally covered by insurance, correct? I mean, reduction might be if it's causing back issues, that sort of thing, right?
Reduction is often covered by insurance.
Yeah.
And reconstruction, in terms of cancer reconstruction, is always covered by insurance by federal law. But in the case of somebody just wanting to look better, now you're pretty much on your own. Very few insurance policies will ever cover that. So the cost, well, it depends on the region of the country. It depends on certain details like what kind of implants you want, where you're going to have this done, whether it's in a hospital or in a surgery center environment or even somebody's office. Generally, the costs range between about $5,000 and $8,000 for just a straight-out breast augmentation. If you add a lift, that usually adds about $3,000 to $5,000 onto the cost of it.
Wow, okay. But that's good to know because you're giving people the ballpark so that they can really be able to tell whether this is something that's very right for them. We don't have much time, but answer this for me. Why do some women want additional surgeries after the first one?
Well, I think that a number of women feel that they're pressured into a particular size or a particular operation. And once they've had a chance to actually go through it and realize that they're happy and that everything is pretty good, then they start looking and realizing that they didn't quite get what they wanted. So they begin, once you've taken the bite of that apple, then the next one isn't such a big deal. You've broken the taboo, if you will. And at that point, they make those decisions. I don't like that. From my standpoint, you spend the time beforehand, and you go over the details, and you very much involve the patients in the discussion, in the decision-making, and all of these things. And that way, by doing that, and I've actually demonstrated that and published on this, at least in lectures, that you can reduce your reoperation rate dramatically once you spend the time doing it beforehand.
That's wonderful advice. Now, that's wonderful advice, and I'm sorry we've run out of time, but that's an important bit of information. Make sure you go over this thoroughly with your doctor so you know what you want and you get what you want the first time. This is Melanie Cole for Radio MD. Let's all stay well.